Let's dive right in. Welcome to this explainer, where we are unpacking the incredibly high-stakes reality of neonatal sepsis. Today, we're looking at the pathophysiology, the major risks, and the targeted management required to protect some of our most vulnerable patients in the hospital. When we talk about neonatal infections, we're really talking about a race against time, where super subtle signs can quickly spiral into overwhelming multi-organ failure. So we're going to break down exactly how to identify, investigate, and treat these hidden threats.
So, what actually happens when a patient is born without a fully functioning immune system? Well, it sets up a massive medical detective story. Unlike adults or even older kids, newborns, and especially preterm newborns, arrive in the world missing crucial immunological armor. They are facing a barrage of invisible assailants entirely without the standard bodily defenses that you and I take for granted every day. To save them, we literally have to step in and become their immune system.
Okay, here is our roadmap for today. We'll cover fragile defenses and risks, the 3 infection windows, investigating the clues, the MIS-FITS differential, and finally, targeted medical management.
Let's start with Section 1, Fragile Defenses and Risks.
Preterm infants, specifically those born under 32 weeks, face some severe vulnerabilities. When you compare them to a healthy, mature immune system, preemies completely lack transferred maternal IgG antibodies, and their own IgG and IgM responses are just drastically reduced. But it doesn't stop at antibodies, unfortunately. On a cellular level, they suffer from deficient alternate and classic complement pathways, which means diminished opsonization. Their neutrophils actually have a deficit in migrating to the lungs and a reduced bacterial killing capacity. And viral defenses, same story. They have deficient natural killer lymphocytes and reduced interferon production. They are fundamentally unprotected right out of the gate.
Now, when you combine that fragile defense system with major risk factors, the threat level absolutely skyrockets. Take a look at the incidence rate. For severe prematurity, it's 1 in 250. Compare that to a much lower 1 in 1,500 in term infants. That is a massive jump in risk. Other general risks include male sex and African American race. But we also have to look closely at maternal factors. Things like vaginal group B strep colonization, prolonged rupture of membranes over 24 hours, amnionitis, and maternal fever. Throw in the necessary but highly invasive NICU environment with its central lines, endotracheal tubes, and broad-spectrum antibiotics, and the risk multiplies even further.
Moving on to Section 2, the 3 infection windows. Timing is quite literally everything here. By dividing the timeline into early onset, late onset, and nosocomial infections, we can properly anchor our suspect pathogens. Anticipating the likely source of the infection is based entirely on how old the infant is and exactly where they've been.
In that very first 7-day window, early-on sepsis is usually driven by an ascending maternal infection from the GU tract, often starting right in utero. Our main culprits here are group B strep, E. coli, Klebsiella, and Listeria monocytogenes. The clinical manifestations are terrifyingly fast, overwhelming multi-organ failure, grunting, pallor, hypothermia, progressing straight into shock, acute tubular necrosis, and DIC. And here is a super critical clinical pearl for you. This rapid presentation is incredibly difficult to differentiate from respiratory distress syndrome or RDS in premature infants. Plus, meningitis is present in about 30% of these early cases.
Let's shift to the late onset window, which hits between 8 and 28 days. This often strikes a usually healthy, full-term infant who has already been discharged from the well nursery. They might present with lethargy, poor feeding, or a bulging fontanelle. If you see this, be on extremely high alert for focal seeding, because meningitis is present in a staggering 75% of these focal seeding cases. 75%? You also need to watch out for osteomyelitis, septic arthritis, and UTIs driven by those early bugs, plus strep pneumoniae, Neisseria meningitidis, and viruses like HSV and CMV. Finally, we have the nosocomially acquired window, running from 8 days until NICU discharge. These are infections born directly from NICU colonization, mostly via central lines and breathing tubes. The striking reality here is that exactly half of these infections are caused by just one single culprit: coagulase-negative staph. The other 50% is a mix of MRSA, fungi like Candida, enteric bacteria, and viruses like adenovirus or RSV. Initially, the signs are incredibly subtle, maybe just some apnea, bradycardia, or temperature instability, before rapidly progressing to shock. Section 3. Investigating the clues.
Okay, so we gather our diagnostic clues sequentially. Step 1 is the CBC, where we're hunting for leukopenia under 5,000, bandemia, where immature band cells make up over 20% of neutrophils, and toxic granulations. Step 2 is the absolutely crucial CSF analysis, In meningitis, you're going to see a CSF to blood glucose ratio of less than 50% and bacteria on the gram stain. Step 3 involves drawing highly sterile cultures: blood, CSF, and urine. And remember, for the urine, it must be a sterile suprapubic tap or a catheter only. Absolutely no clean catches here.
Now, it is absolutely vital to remember the baseline here. A normal newborn naturally has high CSF protein, usually between 100 and 150, and WBC counts between 25 and 30, which are mostly lymphocytes. Knowing what is normal is the only way you can correctly spot the abnormal signs of meningitis during your workup. Do not let a normal newborn baseline trick you into a false positive diagnosis.
Section 4. The MIS-FITS differentiator.
Before we go all in on treatments, we have to rule out the imposters. To memorize the differential diagnosis, use the MIS-FITS mnemonic. A newborn crashing in the NICU might totally look like sepsis, but could actually be experiencing T for trauma like an intracranial hemorrhage, H for heart disease, E for endocrine issues like congenital adrenal hyperplasia, M for metabolic, hypoglycemia, I for inborn errors. You get the idea. From fits, meaning seizures, to intestinal issues like NEC, toxins, and severe asphyxia. You have to run this mental list so you never miss a hidden underlying pathology before deploying those aggressive treatments.
Let's wrap up with Section 5, Targeted Medical Management.
Our pharmacological attack is dictated heavily by the timeline window we established a few minutes ago. For early onset, we target those ascending maternal sources with ampicillin paired with either an aminoglycoside like gentamicin or cefotaxime. For late onset, we use ampicillin plus a third-generation cephalosporin. But notice this critical specific right here. You must add vancomycin if meningitis is present due to resistant pneumococcus. Finally, for nosocomial threats, we shift heavily to vancomycin paired with gentamicin or tobramycin to target those incredibly stubborn hospital-acquired pathogens.
Deploying these drugs is really only half the battle, right? Duration and monitoring are just as critical. Treatment lasts 10 to 14 days for sepsis without a focal infection, but if meningitis is present, that extends to a full 21 days or 14 days post-negative CSF culture. And listen, we must meticulously monitor serum peak and trough levels for aminoglycosides if they are used past 3 days. Why? To prevent serious, irreversible ototoxicity and nephrotoxicity. We have to cure the infection without destroying the patient's hearing or their kidneys in the process. To wrap up our explainer today, consider this. As we master this medical detective work, how can early prevention completely change the odds in the NICU? Maternal intrapartum GBS prophylaxis for things like preterm labor or prolonged rupture of membranes is definitely our first shield. But inside the NICU, meticulous engineering, like maximal sterile barriers for central lines, chlorhexidine antisepsis, minimizing central line days, and prioritizing early enteral feeds, is what truly transforms outcomes. The absolute best way to treat neonatal sepsis will always be stopping the pathogen before it ever breaches those fragile defenses. So, what new protocols might we see next to push these survival rates even higher?